Okay, I do not have any conflict. So basically, I'm going to start with the stroke disease itself, not the clot related or bleeding, but the problem itself, so that the burden of the stroke and the momentum that we have with the stroke medicine. And then go over the basic treatment that we do and where the future is heading. This is a classic example of stroke medicine. The moment we realize that the time is the most important thing, that's when the stroke care took off. At that time, our clock was very simple. Gradually, it got advanced. And in future, we have to have a clock with the crystal ball. So not only we know the time, but we can tell how every individual person is going to do in the future. And that's where the stroke medicine is heading. Just a little bit about stroke and cerebrovascular accident. We used to call it a cerebrovascular accident. Now we know that it's not only the brain. Retina or eye is also part of the stroke. Spinal cord is a part of the stroke. We thought that it was a blood vessel disease or a heart-related problem. But now we know that social determinants of health is more important than the blood vessel or heart or other issues. And then 9 out of 10 strokes are preventable. So we cannot really call it an accident as well, because we can predict in those 90% of cases. That's why the term stroke does justice to this disease, because it comes from nowhere and it changes the whole lifestyle, family, everything because of 1 second. And it's a disease of blood vessels. So if the blood vessel is blocked, we call it a ischemic stroke. If blood vessel ruptures, then we call it a bleeding stroke or hemorrhagic stroke. And if the blood vessel ruptures inside the brain, then we call it intracerebral hemorrhage. If blood vessel ruptures in the covering of the brain or in the spinal fluid, then we call subarachnoid hemorrhage. And the sign and symptoms as well as disability related to stroke will depend on where the brain injury is. So it's the blood vessel rupture or clot that caused the problem, but the long-term disability is related to brain tissue injury. Now, there are a lot of causes, and that's where the social determinants of health and commercial determinants of health comes into action. This is a silent disease to start with, and then the effect is prominent later on. So we are inherently or inherited, we have inherited risk for stroke. And along with that, we have our risk-taking behavior, whether it's lack of exercise, eating unhealthy food, or smoking, or head injury. Those things add to the problem, and then we have a blood pressure issue, or a diabetes, or a cholesterol problem. So that gradually increases the problem and leads to the stroke. So stroke cannot be viewed as just a one-time problem the moment it occurs. There are all these things, those are happening even before someone has a stroke. Now, before understanding the stroke and time factor, we have to understand the brain. In human brain, which is similar to our galaxy, Milky Way, there are 80 to 100 billion neurons. Because of those 80 to 100 billion neurons, and those neurons are limited, they cannot be replaced. And that's all we have got. Because of those 80 to 100 billion neurons, we have 100 to 1,000 trillion synapses, which are the connection those nerves make. And if we look at the human brain, it's only 3 pounds by weight, but which is a 2% of the body weight. But the brain gets 15% of blood flow. The reason that brain needs this large amount of blood flow is this is the most active organ in the body. And even if we say that the brain has a resting state, literally it does not rest. Even during our sleep, brain is actively working. In order to work, it needs oxygen, it needs glucose. And the problem is the brain does not have any storage system. So it has to continuously get blood flow to get that oxygen or glucose. And that's where the problem happens. If the blood flow is interrupted, even for seconds or minutes, then the injury will come. And when the brain cell does not have oxygen or glucose, then it starts to have all the problem. Now, if you look at these numbers, this is where we got the time factor. Every minute when the blood flow is not there, that many neurons are being destroyed. And we know that we cannot replace that neuron. Similarly, those synapses. And every hour that brain does not get blood flow, the brain ages by 3.6. And this is the fact or the point where everyone realized that time is the most important thing in order to maintain the brain health. Now, so the second thing after time, it's the burden. It's an extremely common disorder. 2 to 3% of population have a stroke or can have a stroke. And if we look at the lifetime risk, in United States, it's around 25%. If you look over here, it's a 25% lifetime risk. What it means is if someone is 18 to 65 years old, then 1 out of 4 can get a stroke in their lifetime. And if we break that down to ischemic stroke and hemorrhagic stroke, 17 to 18% is ischemic stroke, and 7 to 8% is hemorrhagic stroke. So it's extremely common disease, extremely common in average person's lifestyle or lifespan. And then there are, even if someone does not have an acute stroke, if they have a risk factor, there are gradual changes in the brain that can lead to memory loss, change in lifestyle, change in personality, those that we call vascular dementia. And vascular dementia is second most common after Alzheimer's. Now, again, back to the main thing. It's again the time. Everything that we do is related to time. And that actually changed the whole paradigm in stroke treatment. Benjamin Franklin was the first one to identify the time value of money. Then the cardiologist identified time value of the muscle, and then we came to that point. Now, stroke is a success story, and this is the best graph. If you look at 1900, heart disease were #1 killer. Stroke was #2. And gradually, the changes are happening with advancement in the medicine. And now stroke is #5 cause of death in United States. If we look at the global population, is still #2, but we do have a significant advancement. And the trend is going down, even for the heart disease, but the difference is huge here in comparison to here. And then this is translated in every race. We still have a lot of work to do in terms of health disparity and social determinants of health, but the trend is going down in every gender and every race. The reason for this is not related to clot-busting medication, is not related to thrombectomy. Those two therapy does prevent a disability, but they do not prevent death in the population health. The reason that death is improvement in treatment of hypertension, whether it's the awareness or whether it's the control. And those numbers are looking really good. Part of it is population health effort, and the other part is now we have better and newer medication. The blood pressure parameter, when I was in medical school, the normal blood pressure was 140 and below. Now recently it was changed to 130 and below. It's because of bleeding stroke. They found that when the blood pressure is reduced to much lower level, then the risk of bleeding stroke goes down tremendously. And one of the reasons for this change is a stroke. The outcome of blood pressure control in stroke was so profound that they had to lower the guideline as well. The other thing is diabetes. If we only think about diabetes control with blood sugar, then the outcome is not that good. If you look at the orange bar, But if we combine multifactorial change, whether it's blood sugar, diet, exercise, blood pressure control, sleep apnea, and all those, then the outcome looks really, really good. And this is in the blue bar. Atrial fibrillation. Atrial fibrillation is one of the most common cause of a stroke. And the stroke caused by atrial fibrillation tend to be more disabling and more fatal. They have the highest fatality rate if someone has a stroke and that stroke is related to atrial fibrillation. And we have a growing population. In 2030, the rate of or the prevalence of atrial fibrillation is going to increase. Now, because of better monitoring and better therapy, we are at this point that if we can identify atrial fibrillation on time, they can be on blood thinner with the newer blood thinners which have equal efficacy to prevent clotting stroke like Coumadin, but much better efficacy to prevent bleeding stroke. And it's much easier to use, they do not need any diet restriction. So with those new therapy, atrial fibrillation related stroke will be less. But if we look at United States, specifically in the rural area, still only 50% of people who are above 75 years old with atrial fibrillation are getting the treatment. So this is the area where we can improve. Same thing with cholesterol. If we can reduce the bad cholesterol as low as possible, then the outcome is better. The reason for this improvement in terms of, if we look at the different years, now the trend is this way. And that is one of the main reasons why our stroke outcome data looks so good. Even if someone is taking those statin, even if they have a stroke, the stroke magnitude is much smaller. Their recovery is much better. And not only diet, but with the statin, newer statin, as well as now we have injectable medication that can be given to people who cannot tolerate a statin. Statin, if we use a statin in the entire population, then only in 40 to 50% of people we can reach the target. Even if everyone takes the statin, there will be 50% who would not reach the target. But now with better medication, we can achieve that target as well. Now, stroke system of care. And this is one of the game-changing things that happened. What it means is a stroke center. If someone has a stroke and they go to a stroke center, their outcome is much, much better than people who go to non-stroke center. And one of the main reasons is when they go to a stroke center, stroke detection is earlier, atrial fibrillation detection is earlier, they prevent any aspiration pneumonia or deep venous thrombosis, clot in the leg. Even if someone has a clot in the leg or aspiration pneumonia, those are treated earlier. Everyone who is discharged from stroke center are screened for atrial fibrillation. They go home on aspirin, statin, and they have a monitoring system in place. Now, those are the stroke outcome number, but stroke center actually changed neurology as well. Before stroke treatment, we were not that active in terms of coming to the hospital within 15 minutes, 20 minutes. We would be taking call over the phone. But this changed the whole thing, and now if someone has a vision loss, if they have an eyesight problem, ophthalmologists tend to refer them to neurologists because ophthalmologists do not have a way to come to the hospital to evaluate and give clot-busting medication. And if we maintain that amount of energy and intensity in stroke treatment, then only outcome will be better. In our center, we have extremely good result. But there are other centers, or the rural hospital in Western New York, or if we look at the global perspective, there are still a lot of work to be done. In terms of stroke treatment, the way I would summarize this is, first is the diagnosis. Now we have clinical thing, clinical examination that we do with the NIH scale as well as neuro exam. Then we have CT in order to rule out the bleeding, or CT angio to look at the blood vessel. Then once stroke is suspected or proven, the next step that we have to think is how to open the blood vessel. If it's a large blood vessel, then first clot busting medication and going in to open the clot. If it's a small blood vessel, then we may not be able to open. Then how do we increase the blood flow surrounding that area? We can do that in multiple ways, and we can increase the blood pressure. We can stop the antihypertensive medication for 24 to 48 hours so that the blood pressure remains in the higher level. The reason we are doing that is to maintain the blood flow to the surrounding area so that it can help. That's the second step. Then third step would be improving the rehabilitation. Now I'm going to skip a few things. Since we have this treatment, but still we have a lot of work to do because only around 13% of people are getting clot busting medication. We have really proven thrombectomy therapy. Dr. Siddiqui will be talking about that. That is also available to only 5% of population. If we look at the global, only 1 to 2% of people are getting this treatment. Again, stroke prevention, instead of thinking of individual risk factor, we have to think of three major things. Metabolic risk factor, which includes diabetes, cholesterol problem, or high blood pressure, or behavioral issue, risk-taking behavior like not exercising or not eating healthy or smoking. And there are environmental factors as well. So when we think about the prevention, we need to think about these risk factors. There are new things coming in terms of antiplatelet or blood thinners, or even in cholesterol control. We do have a new therapy in pipeline. Similarly, if we treat sleep apnea, the stroke outcome will be better, and we are part of that trial that's evaluating the role of sleep apnea. Similarly, combination therapy. Now, the other thing is, how do we reach to the people who are not getting these type of modern advanced therapy? And that's where the telemedicine comes. Telemedicine has equivalent benefit in terms of acute stroke treatment, whether it's done here in the Comprehensive Stroke Center or with telemedicine in rural hospital. So this is the new advancement. Similarly, we have to find a way to address the global burden of stroke. With our experience with the stroke center system of care, if we can take to a developing country, then the global stroke outcome will also improve. Similarly, one of the major problems that we are having at this moment is how to predict the outcome. If we look at the weather forecasting, they have 100 years of data, and they can extrapolate based on that 100 years of data, whether it's going to rain or not. But we don't have that opportunity at this moment. With AI, that may change. With functional MRI, that may change. And similarly, stem cell is also in the pipeline, but it's still in the animal research stage. The way it's being thought is it was done for bleeding stroke, where they can put the mesenchymal stem cell to see if that regenerates and turns into the neuron which can function. Still in very early research stage. Neuroprotective agent, a lot of trial has been done, but nothing has been significantly successful. Exercise remains one of the best neuroprotective. Personalized medicine. So future, like they are doing it in cancer. Whenever someone comes with the cancer, they evaluate the gene, and based on the gene, the treatment is decided. And if we can do that with the stroke, with genetic makeup, then that will be a more personalized medicine. Right now, we can do this with blood thinner. Clopidogrel has, there are 20% of people in the United States, 50% of people in China who do not have that enzyme to make clopidogrel or Plavix work. So we can do that genetic test, and if they don't have that enzyme, we don't have to give that medication, and we have the alternate. So If the genetic makeup is known, then we can use that with the blood pressure medication, with a statin and those. Similarly, wearable technologies, Apple Watch can detect atrial fibrillation, it can detect sleep apnea. And if we have a system of using that for individualized care, then that would be one of the main things. At the end, AI. We have so much of data, and if there is some help using the machine learning system to use that data to predict the future outcome, that would change stroke medicine further. And I think we are heading in that direction. AI can help us with prognosis. If we know that every person is different, every brain has a different makeup, and the blood vessels are different, but we don't have capacity to individualize those things. Thank you so much. Yes, Dr. Lal will be talking about that. She has a presentation on rehab. But these preventive things that I talked about, that is going to be applicable in preventing the next stroke as well. But the neuroplasticity and rehab, Dr. Lal will be talking about that.
Yes. What is the new option for statins? I've had 3 strokes. Luckily, I had the TPA, but the statins don't agree with me, so what is the new option?
So right now, the one which is proven is called PCSK9 inhibitor, and Repatha is one of those. So those can be used.
Is it a prescription?
Yes, it's an injectable.
Oh.
So you can talk to either neurologist or cardiologist or your primary, and they can prescribe it.
Any knowledge of etanercept being used paraspinally?
Say that again?
Etanercept being used paraspinally?
No.
It's Enbrel?
No.
Thank you.
Okay. Basically, CT and CT angio can detect there is a stroke after how many hours of onset?
Say that again, CT?
The CT and CT angio can detect that there is an active stroke after how many hours of occurring? Like how many hours
So,
of stroke is there?
yeah. So it all depends on the brain cell and the blood flow. CT is not very sensitive to identify a stroke. If we get the MRI, then MRI can detect within 30 minutes. CT, if there is a large stroke, then in first 3 to 4.5 hours, we may see some changes, but we cannot be 100% certain. After 6 to 8 hours, if it's a small one, if it's a large one and there is no blood flow at all, then maybe 4.5 to 6 hours. So the summary, the bottom line would be, with CT, it's extremely difficult. CT angio, it will be extremely sensitive. If we see the clot there, then that tells us that the blood is not there. But CT angio can only say the clot is there in 20% of a stroke. Almost 80% of a stroke are not a large vessel occlusion. Those are other type or a small vessel occlusion. So if you are looking for the time, then I would not go with CT and CT angio. Like someone may have large vessel block for 4-5 days, and they could still be not having symptom if they have other ways to support that area.
You want to mention hemorrhagic stroke with CT, though?
Yes, thank you. With bleeding stroke, CT is extremely sensitive. It would be seen immediately. If it's a small, then maybe we need to repeat, but it's very sensitive. Thank you, Gil.
One last question. You touched on genetic markers. Are you saying that, like, if there's a family history of strokes, that you could be tested early
So that will be the future. There are monogenic or there are genetic strokes that happens usually in the younger patients that tend to run in the family. Most of the strokes are not directly related to gene at this time. But there are situations where we can use gene to identify the best working therapy. And that Plavix use is one of the examples. But we don't have any more at this stage to do that other than Plavix.
Okay, last question. What I've read is that stem cell therapy is very positive, especially for chronic stroke patients. I mean, they're doing stem cell therapy in California, in Pittsburgh.
So I can tell you all about it. It's not that well established. It's being done by a guy by the name of Gary Steinberg. Gary Steinberg is the chair of neurosurgery, was the chair of neurosurgery at Stanford till a few years ago. And he took these people who had chronic paralysis and did a couple of cases, 4, 5, 6 cases. And in some of them, they had this almost miraculous return of a lot of function. The question that is completely unknown is, does that have anything to do with stem cells, or is just putting a hole in the brain in a part of the brain that's hurt, create an inflammatory response that causes a reaction? Because the timeline of that response was 24 to 48 hours, which is way too early for any stem cells to have done anything. Nobody else on the planet, including his co-investigators, have as yet reported a single paper with peer-reviewed literature to suggest it's been replicated. So as far as I'm concerned, I know Gary very well, and I've offered him that we would love to be a site. We're one of the busiest sites in the country. So I don't put a lot of stock till people are really out in the open and actually willing to actually enroll patients. So I would not claim there's a lot of value for stem cell. At this point, there's none. Pittsburgh is supposed to be their second site because Dr. Steinberg's son is an attending at University of Pittsburgh. But he has not reported any results either.
So this is Dr. Adnan Siddiqui,
Hi
who's
there.
our CEO of the GI.
Thank you so much, Dr. Kandel. Thank you very
I'm going to talk a little bit about making an innovation ecosystem. So what we're trying to do here is, you know, everybody talks about Silicon Valley. Why do they call it Silicon Valley? Because that's where chips were invented and everybody was making computers in Silicon Valley. So we're trying to recreate similar sort of med tech innovation to happen here. Now, in Silicon Valley, it happened because Stanford and some of its faculty really invested in that technology. That's sort of what we are trying to do here. It's a very similar model where we are trying to create medical technology sort of focus right here. And that's sort of the goal. And so the partners we have are, I'm a neurosurgeon, so I always put UB neurosurgery first. But we have a translational stroke center called Canon, which does all basic science in vivo and in vitro. We have the Gates Vascular Institute, which is Kaleida Health, and then I'm full professor at the University of Buffalo, which is located right up here. So, and my life sort of includes all these sort of realms. These are disclosures. This is what we call conflict of interest. These are things that are my personal conflicts. So you can sort of get an idea as to what I do just by looking at this. So the top half is my NIH grants, so a lot of basic and translational research. The second is all these technology companies that I'm partnering with to develop new toys and tips and tricks to treat brain diseases better. And then I help the big companies by helping them chart the right course. That's my advisory. And the last thing is actually running clinical trials. And so I do a lot of clinical trial activity as well. So why Vascular Institute? Why don't we have a neuroscience institute? Because Nick Hopkins, my mentor, the guy who really founded this entire building, this concept, was passionate about trying to really make an impact locally. And the number one cause of death and disability in Western New York, or the number one cause of death and disability in the world, is vascular disease. Now, the vascular disease affects the heart, the head, the lungs. And the problem is when you go to the cardiologist, you don't go to the neurologist. When you go to the neurologist, you don't go to the vascular surgeon. When you go to the vascular surgeon, you don't go to the interventional radiologist. Yet, disease of the blood vessels affect all blood vessels. If you got plaque in your neck, you got plaque in your heart. You got plaque in your heart, you got probably plaque in your legs. And so what Nick wanted to do was put all the clinical practitioners who deal with vascular disease into one place because they were all living their separate siloed lives. And then researchers, we used to have research building. It was called the Biomedical Sciences Building. It was like 4 miles east of here, the South Campus. And we'd get to go there maybe once or twice a year, and we'd have to take the day off from work and disrupt all clinical activity to actually talk to our engineers and cell biologists. So what he wanted to do was break down the silos, put everybody into one physical structure for the future of vascular care. So that's what he did. That's where we are right now, where we have all the specialists, including the ones that we have put together for you today. And so that's Nick Hopkins, and he sort of believed that the blood vessels were the gateway, were the Eisenhower highway system to every organ system in the body. And so if we could figure out a way for everybody to work together to create best-in-class vascular treatment in a not-for-profit environment, we could maybe do entrepreneurship, create job creation. And the reason it's called the Jacobs Institute is because not of Jerry Jacobs, who runs Delaware North, and we all pay money to buy hot dogs and beer. That's not the Jacobs we are named after. We are named after his younger brother, Larry Jacobs. Lawrence Jacobs was a vascular neurologist, brilliant man, who actually invented interferon therapy, which is the mainstay of treatment for multiple sclerosis. Eventually, that patent and work was sold to Biogen. Biogen took it away with them to Boston and never looked back. So while we have the Jacobs Neurologic Institute, the Jacobs Institute, these are all reflections of his legacy. One of the things that Nick wanted, who was a very good friend of his, and his brother Jerry wanted to do was to maybe bring that entrepreneurship back to Buffalo so that maybe the next radical therapy doesn't have to leave to go to Boston or New York or to the West Coast. So Nick's idea was to accelerate the development of next generation technologies in vascular and neurologic diseases through collisions of physicians, engineers, entrepreneurs. And so we are located here, not for profit, and our goal is, and this is part of what we are doing today, is providing an impact to our local community by providing education and leadership opportunities. We do that for students. We run summer school and internship programs throughout the year. So you all know where we are, right in the middle of the medical campus. What you probably don't know is right below us at the Gates Vascular Institute, we do about 20,000 vascular and neurologic procedures a year. It's one of the busiest hospitals in the entire Northeast. And when you pair that up with the largest SUNY campus, 35,000 enrollment, with every conceivable research school part of the ecosystem, we really need to leverage it, and we don't leverage it enough. Now, neurosurgery leverages extremely well. We are ranked, even though we are one of the smaller departments in the country, in one of the really smaller cities in the country, we are ranked 7th nationally in terms of academic productivity. We produce more research and more clinical output than the 150, 200 other programs. And so what we do is we have this partnership. We have the clinical partner, which is Gates Vascular. We have the research partner, which is UB. And then the entrepreneurship, which is the Jacobs Institute. The other thing might not be known. This is a slide that I made because these are all neurosurgeons. These are all people who are world leaders who are trained here in Buffalo. I mean, you can name any major academic institution, and they have a Buffalo-trained person who's been here. Lots of research, lots of trials, lots of accreditation, lots of clinical data. We work with FDA, we work with CMS, we work with the NIH, and not in just minor capacities, but leadership capacities to really be able to move things forward. We also do a pretty cool thing, which is where the idea of this place was born, is that we run a multidisciplinary conference in Jackson Hole every year. We actually run 3 of them. And they're designed to bring all different specialists together to actually discuss problems. And the only thing we do is we discuss failures. So we talk about when things went wrong so that we can identify what causes errors, whether it's technological errors or human errors or decision-making errors, so we can all learn and not repeat them, because that is something that often is missing from cultures, to be able to openly discuss. So it's a very special conference. It's the only one of its kind. We do a lot of training programs. Hillary visited us some years ago, so that's me with her. I had to treat some strokes while she was here on models. And then we do a lot of broadcasting. This is Chi Kim, our electrophysiologist, who's training doctors in Africa as to how to do cardiac procedures. We just broadcasted, I told you yesterday and today, to the Congress. We broadcast surgeries to all over the world. And what's really cool is that all of this happens in this one physical building. We don't need to go around the campus to do it. It's all in one physical building, whether it's working with clinical trials or doctors or entrepreneurs. And then that's where the JI comes in. What does the JI do? It does all of the device development all in one place. So we can come up with an idea, make the prototype, test it in models, revise it all the way till it's ready to go to human beings under the FDA guidance. And so we do a lot of what are called observerships, clinical immersion programs, to figure out what the problem areas are, then come up with a concept to create a solution. Then our engineers develop the tool all the way to actually being able to do clinical research and bring it forward. So in the end, I'll sort of summarize here and I'll sort of move.
I didn't get that. Could you try again?
No. So what we basically do, and I think I'll stop here because I'd like to get back to the stroke thing, is that we harness the potential of the incredible talent that is located below us at the Gates Vascular Institute and above us, the researchers at UB, and put it all together to see if we can make new devices, new tools, and new clinical trials to change the way we treat vascular disease. So that's what we're doing. And the vascular disease that I am most interested in is the subject of the topic today, which is stroke. All right, so I'll stop there. Pam, is that good? Okay, good. Thank you.
We've invited a panel on professionals to talk today about what are the current and future treatments in rehabilitation. So I'm going to ask the panelists to each introduce themselves and talk about their role in the rehabilitation process. So maybe we'll start with you, Doctor.
Sure. So I'm Dr. Erin Jerzewski. I'm the Chief of Service for Rehabilitation for Kaleida Health. Work mostly on the inpatient medical rehab unit here in the hospital, and I also do outpatient work as well.
Intervene, physical therapist. I work on the acute service, primarily with neurology and neurosurgical services. I've been a PT in the system for 23 years, primarily working in the neurologic field.
And is it true that you were not a PT, that you trained to be something else?
I have a degree in education, so yes, that is true. But never made it to the classroom, and thankfully that's a good thing.
I'm Erin McBundy. I'm an occupational therapist at ECMC's outpatient, and I specialize in neuro rehab. Some of my specialties are I do driver rehab and wheelchair evaluations.
Hi, I'm Hank Cole. I'm the Director of Rehabilitation Medicine here at Buff General and GVI. I am a physical therapist, but have not treated patients in a number of years, but oversee the physical, occupational, and speech therapy departments. So I've been with the organization about 22 years.
And my name is Melissa Archer. I'm a psychiatric nurse practitioner, and I'm here to discuss the mental health psychiatric effects of post-stroke on not only the patients but their families.
So maybe each of you could talk to some of the most recent advances in your particular area that are showing promise for rehabilitation. You can go, you don't have to go in.
Okay, I'll go first. So in outpatient, we see people obviously for months, which is nice. So there's a lot of advancements in doing repetitive task training. So typically in the past, you would do like 30 to 50 repetitions of a certain task, but now they've amplified it to doing something called action observation. And what that is actually having a patient observe a task and then actually executing it. And when we notice people do this action observation, it elicits the mirror neurons in your brain, which help with that neuroplasticity. So it's almost giving them a mental practice when they're observing a task first. So in the clinic, we'll have somebody watch a video of whatever task they want. So right now I have a patient who wants to be able to pick up a cup of water so they can drink, right? So coffee, anything like that. So maybe we'll focus on a video where we're seeing an arm kind of reach out to grasp that cup. And then they're gonna watch that video on repetition for about a minute, and they're gonna see that view from the front to the side and maybe their point of view. And then after they watch that for 3 minutes, we're gonna have them actually perform that activity. And what we're noticing is they're actually getting better movement in that arm, better ability to do functional activities, which is really exciting. And also at ECMC, we do something called modified constraint-induced movement therapy. We do a 6-week program in the winter where we have people come for 3 hours Monday, Wednesday, and Friday. And they basically focus on functional activities that are meaningful for them. And I don't know how many people are familiar with modified constraint-induced movement therapy, but traditionally CMT was 90% of the day their unaffected arm was being constrained. But modified is about 5 hours a day. So you're really getting people to do that function by using just that affected arm. But you do have to have a little bit of voluntary movement in that arm. So it can be kind of tough if you don't have any movement because you have to have a little bit of wrist extension, a little bit of those finger extension. But the most exciting thing now for those chronic stroke cases, right, is that there's a new thing called vagus nerve stimulation that's kind of been coming out. There's some research articles that have been out since 2021 where they're basically implanting a device onto that left vagus nerve, and then they're stimulating it using a magnet, and it's sending neurotransmitters are going through that brain, helping with neuroplasticity, so it's releasing acetylcholine, norepinephrine, all those important things to help with movement, right? And so what they're doing is when they pair that now with occupational therapy, and you're having an intensive, again, high repetition kind of activities going on, we're seeing a lot of improvement. And in these studies, the thing that's so exciting, people are 9 months post-stroke, but also 10 years post-stroke are actually getting returned to that arm, which is really amazing. So we're seeing improvement in motor function specifically. So.
You know, I was at this, on Saturday, we organized an innovation symposium at the Congress. And there were a few technologies that I came across that I thought would be absolutely sort of fabulous. So, and I wonder if any of you have any experience with that. The first is called transcranial magnetic stimulation, or TMS. So basically what you take is you take a magnet and you try to stimulate it, because magnetic fields kind of go through bone and stuff without too much trouble. You can actually stimulate brain cells to rewire the brain. And this company was called Neurolutions. And by the way, these guys, they had stopped by at our place a few years ago when they were very early on, but now they got FDA approval for their, it's like a helmet that you wear, and then depending on what you're trying to stimulate, so if it's right side, it'll be the left brain and vice versa, you can stimulate the brain to actually get some return of function. And the way they do that is that they have this little robotic arm, they call it the IPSI hand, and you put the hand in this little robot, and it synchronizes with the stim, so it kind of trains you. Every time it stims, the robot kind of moves your hand a little bit, but it strengthens the circuits, the neuroplasticity you're talking about. I wonder if any of you have any, have you heard of this, or?
Yeah, I have some experience, with those. I've seen those, I've read a lot of the research, and there's a couple of different ways of doing them. One is you stimulate the affected side, and the other is actually you inhibit the good side. So there's a couple of different ways of doing that. It's magnetic stimulation, but then there's also direct current stimulation as well. And again, there's anal and cathode stimulation there, again with similar sort of principles involved. And generally the data on that, is positive, but nobody has a protocol that works. This protocol works better than that protocol. So it's still sort of being tested out in terms of what should you do, what is the best way to do it. And then also with that, how does it compare to the traditional physical therapy? What most people are doing is they're pairing that with traditional physical therapy. We'll do some type of stimulation and do therapy right afterwards. And that's when we're seeing the most result out of that.
Anybody else with and there was another technology I heard that I saw. This was, I think they showcased it here a few years ago as well, or maybe just before the pandemic. This one is by Penumbra, and they use keyword AI to sort of train people to respond to visual cues. It's like a virtual environment, you know, how Facebook has this meta universe or something like that where you have your avatar. So basically what you do is you put this helmet on, which is completely immersive, and in that immersive environment, you think you're doing things. And that sort of passive, so that was another interesting technology that I heard about that I thought, oh wow, this is fascinating, where you're kind of practicing things at home, you put this headset on, and then again, just like the other one, the IPSI hand, here you put these gloves which have sensors on them that can kind of detect how much movement you actually have from them. So you're able to sort of hopefully build up on it, and because everything is now being measured, I mean, they had limited, but really interesting data. So any thoughts on this, the headset concept, immersive environments for patients with strokes?
Yeah, virtual reality is really interesting because there's a lot of new research coming out with it. I think it's a great tool because if it's motivating, you know, to the people who want to use it, it just gives you another avenue to try to use that arm, right? So it's, again, giving that mental practice, but then also if some virtual reality devices actually let you use little hand things, you know, like the Oculus. I don't know if anyone's used the Oculus, or that helps simulate, you know, kind of arm movement again. So I do find that there's a lot of interest in that.
Well, I think mental imagery is actually well documented to be effective. So I think we lose sight that, you know, you don't necessarily have to have a fancy device. Right. You just, you go into your mind and you practice the things that you want to get better at. fMRI has proven that when you think about something, those areas of the brain fire up. Precisely. So, you know, it's nice to have a fancy device, but I also try to instill in my patients that just spending some time every day thinking about the things that they want to be able to do in the setting, in their own mind of what they did before all this happened, I think is important, and not to be, you know, don't lose sight of that. I guess while I'm speaking out, you know, from a PT standpoint, I'm just going to piggyback a little bit on what Erin said, and that is, you know, groundbreaking for PT is really focusing in on two components of getting better, and that is lots of repetition, right? Lots of functional repetition. You know, not lifting a weight, but reaching, not kicking your leg out in front of you, but walking, and over and over and over. You know, mass practice was a big, you know, topic, you know, probably 7-10 years ago. And they thought that was going to fix a lot of the issues we had with getting people better. What they left out and what they found out when they looked at two bodies of people doing maybe traditional therapy and another body of patients doing a lot of mass practice was the intensity component. You cannot get better if you're not challenging your body with intensity. So I think we need to focus, really focus in on that piece too, whether it's measuring patients' heart rate. And unfortunately, in our patient population, there are a lot of patients who are on cardiac meds that don't allow their heart rate to rise. So you use, you know, like the rate of perceived exertion. So you use a scale to figure out, or just simply that I like to call it, it's called the talk test. You know, if you can talk easily through an exercise, then you're probably not working hard enough, right? But if you get a little breathy, then you probably are working hard enough. And so those two components absolutely have to be paired. Maybe not so much in the acute phase, which is where I spend a lot of my time, but certainly in the subacute phase and in the chronic phase, you know, lots of practice and putting in that intensity.
Now, let me ask you another question. Maybe you can answer this about the value of sort of the mental state or mental health as a key component of recovery. I think there are a few factors that affect human motivation to achieve than their mental status. So how big a problem is that for patients with stroke?
Patients that before they even have a stroke may have some mental challenges, mental health challenges. But after stroke, you're dealing with a lot of, post-stroke, they're dealing with a lot of, trauma. They're dealing with some PTSD because of what just happened. Dealing with the fact that they're grieving a loss of what they had in terms of their functioning and maybe their quality of life and their living arrangements and things like that. And then, from a clinical standpoint, depression, anxiety, and then there's something called pseudo-bulbar effect, which usually affects patients that have like brainstem strokes, but it can affect anybody with any type of stroke. And some patients will have no effects, but some may have all and some. So, the therapies that are out there, somebody mentioned like self-guided. When a clinician does it, we do guided therapy, but self-guided therapy, because you may not be able to afford the Oculus or other, when you're looking at different communities and different socioeconomic factors. So there's talk therapy, there's cognitive behavioral therapy, there's so many different types of therapies. And then that in conjunction with medication, which goes along with, what type of stroke did we have, right? So that's very specific. So you can have SSRIs or use mood stabilizers, and one or the other or a combination of both. So those are some of the things that are, kind of groundbreaking in terms of treating post-stroke psychological disorders. And I don't want to forget the caregivers, of these families. They need that support as well, because it is quite stressful. They're also mourning the loss of what could have been, right? So yeah.
Yes, one of the challenges that we have, again, it's partly reflective of that siloed mentality of all types of medicine, where everybody says, we do these handoffs, right? So they come in with an acute stroke, and then Amit will give TPA, and then I will do a thrombectomy, and then Amit will transfer over to Gil, who will see this patient out as an outpatient to deal with their stroke problems. And you guys will get engaged and involved with some inpatient and then maybe some outpatient PT. But there's no real sort of continuum or quarterbacking of at what stage does what need to be done. We sort of expect the primary care physician to maybe play that role, but the fact is they're completely not knowledgeable about stroke, even though it's a common thing. So do we have in our community sort of support groups specifically dedicated to stroke that are actually functioning? I've heard of a few, but Kathy, are there any real support groups in Western New York?
I've just got a few people together casually, that's all I know.
It was awful. I gotta admit, it was heartbreaking not to have anybody to turn to, and you become suicidal, and there wasn't the emotional support. Doctors dismissed it, just like you said. The primary care people felt it wasn't a problem. They didn't know what to do. You went to the neurologist, they didn't know what to do. You went to a heart doctor, they didn't know what to do. I felt I was shuffled from one person to the next. At one point, I was given so much psychiatric medicine, and I was suicidal, and I could have taken it all, and nobody really cared except for my family. And it's a shame. But if you have cancer, I felt like Roswell has yoga. They have many things, so at one point I pretended I had cancer.
Yeah, I think we have done a better job with cancer. I think there's coordination of care, all the way from diagnosis to recovery, or end of life care. I think it's a much better oil system. how do we go about maybe changing that? Because stroke is the #1 disease. Gil, any thoughts on how we can reorganize our healthcare to be able to take care of this?
It's not just Buffalo. The coordination of care in a lot of neurological diseases is suboptimal. But stroke is so common, it really shows up prominently. At least for neurology, I don't know how it is with neurosurgery. We are 20% short neurologists in the United States. It is the subspecialty that is the most short as far as practitioners. And that has to do with a lot of things. Neurology and neuroanatomy can turn a lot of medical students off. We try to encourage them and their interest, but it's hard. It's a harder area of anatomy. And the other thing is just policies, compensation, and so forth. And I know my academy, they're having their big academy now. Our big academy is American Academy of Neurology, and they're constantly talking to the federal entities, the regulatory side, and also the legislative side, on how to make neurology more attractive. Right now, there's nowhere near enough neurologists to handle all the Alzheimer's disease patients, and now there's a medication that has some efficacy. And so this is a lot of insurers aren't going to pay for it, it looks like. But anyway, these are all issues. But stroke really comes to the surface with very common things like stroke and Alzheimer's.
Because it's so common. I mean, there is no other more common neurologic disease than stroke. It is the 3rd leading cause of death and the #1 cause of adult disability.
Yeah.
So
for bad things, headache is very, very common. So, 40 to 50% of the population has problems with headache. But for something, that really causes significant disability.
Right. And so, yes, please.
Hank can talk about, we are planning for support.
We are, yes. So we've met a couple times as a group, and we were looking at creating a group that is community-based, that would be centrally located in Western New York, at one of our facilities, not on a hospital campus with free parking and all of that. But like I said, we've had two discussions on it. One was a little more formal. We talked about it before this meeting, about formalizing that a little bit more, because we have been hearing, there is no support. There's plenty of people who would love to be guest speakers. There's yoga instructors who would love to come teach a class. So I think we're going to get there. It's just a matter of building it again. We had a small program here that we ran out of the hospital prior to COVID. COVID came, everything stopped. So I think in the interim, what we've talked about is we're going to try to get the smaller program here started back up, at least so there's something for people to go to. And then as that's running, we'll start working on getting this bigger program that we wanted for the entire community with easy access kind of thing up and running as well. So I think we'll see something coming.
Yeah, I think of the opportunity that is there because I think there is a camaraderie in talking to other people with the same problem.
There is.
You can share resources and experiences, and you feel the sense of community that you're not by yourself, you're not alone. So it's been proven to be effective no matter which disease disorder you talk about. To have people get together, and support groups are effective. So it'd be nice to have something like that, and I wonder if maybe the Jacobs Institute could also help in that regard. We used to have a brain aneurysm support group that we ran. Again, it fizzled away during COVID, where every 6 weeks or so, we would get together with some coffee and soda and have a physician come in and talk a little bit about some kind of recovery process. So what you were saying.
No, I'm really loving hearing about the support groups, because I know if you go to like the Erie County, I believe, Department of Health website, you can find support groups around eating disorders and depression and things like that. And, a lot of patients, they deal with, post-stroke depression, anxiety, and things like that. So you can go to that, but something very specific just for post-stroke patients and all the challenges, very unique. That's not there. But when you talk about trying to engage the community, what I didn't say earlier was one of my many things that I do. I'm also the Chief Operating Officer of the Buffalo Urban League, and we are very interested in the communities, and not just in all communities.
Sure.
And ways to engage the community, there has to be a very robust campaign for advocacy, education, doing tablings, in their neighborhoods, having people that look like them talk to their communities about the risks of strokes and all the different aspects of it, and doing that in a very strategic, intentional manner. And other campaigns that I know from the Buffalo Urban League standpoint that we have ran have been highly successful using this same, it's like a, just like a path that we use, and it's the same roadmap that we use, and it gets the work done. So I think that may be a great way to do it. And if you're doing that, I would love to partner. I don't know if I'm supposed to say that right now. I would love for us to partner.
Yes.
The more heads, the
I
better.
love the American Heart Association. We raised this money doing bike rides and everything, and I said, well, I got all these people, family members, to ride bikes, but you're not giving it to the stroke people. And they kind of said, well, we're going to give it to the heart people. But there is money that was donated for stroke specifically to the American Heart Association. So if you just call them on it, and I met Kathy because M&T donated money for stroke, but then it was just given to the American Heart Association. But there are funds that were specifically given in honor of stroke patients, the American Heart Association. So if you started something, I would just mention that.
Sure.
Go ahead. Yes.
I don't hear anything about the number or the capacity of our acute rehabilitation centers and our subacute rehabilitation centers in our area.
Sure.
And also, the primary care physician is very important to the person who has gotten afflicted with these
The primary
problems.
care physician is the most important physician you can have, because they know you the best, they know you the longest. And it's a real privilege to have a really good primary care physician, and it's a real catastrophe when you don't have one.
Well, one of the reasons you need to have one is because they write the prescriptions to get further rehabilitation care, whether it be occupational or physical therapy, and then without a primary care physician to back you up, you're going to be left stranded or paying out of pocket or whatever. And finally, the Medicare limitation, every 3 weeks you undergo a reevaluation, and they have committees that do not know about these afflictions, and they always turn you down, except if you have to appeal, and then you probably have a chance to get rehabilitated again. But what is the status of the acute and subacute in our area?
Right. So acute-wise, Andy's one of our acute therapists up on the neuro unit, but treatment on the acute side, and Andy, correct me if I'm wrong, starts within 24 hours of a patient getting up to the unit. We get the patients evaluated, we start getting the rehab going, we get their recommendations as to what the next level of care is going to be. Within Buffalo General Medical Center and the GVI, we do have a medical rehab unit, okay? And in June of this year, that unit expanded. We went from 28 beds to 34 beds. We completely gutted the whole unit over a 2-year period. So now the unit that we have here is brand new. And we're seeing about 50% of our patients are stroke patients, which makes sense being in the building that we're in. And a stroke patient on the acute side, they can be there anywhere from 7 days to months, depending on what their individual needs are. So, once they finish then, say with the medical rehab unit, if they need to go to subacute, there's a lot of subacute rehab facilities across Western New York. We have some that are preferred. Generally, people try to go closest to their home, right, for family and things like that. And then if further therapy is needed after that, then that's when we would pick a patient up on the outpatient side of it. So our unit, if anyone has, I know we don't have time today, and not all of you work here, but the unit is gorgeous. What we did is we went to one of the largest rehab hospitals on the East Coast. A team of us went there, spent an entire day there looking at their neuro floors. Took a lot of the concepts from there to help neuro patients, mainly stroke patients, have an easier time while they're in a medical rehab unit, because our goal in the medical rehab unit is to get a patient as independent as possible before they leave the unit. So we made things in the room like lower sinks, making sure you have 2 grab bars next to the toilet, making sure the toilets are low enough that a patient can get on and off with a wheelchair. So a lot of little things like that we did. We also created, most of the rooms are private rooms. We do have some semi-privates, but most of the rooms are private rooms. So I'll let Dr. Jerzewski or Andy pick up with anything.
Yeah, so when you mention the primary care physician coordinating care, so I'm a physiatrist, and when I see people here, that's a lot of what I end up doing. I end up coordinating the care, the rehabilitation. So when I write a prescription, when somebody leaves the rehab unit, almost everybody still needs some type of therapy. So I write a specific prescription for the next therapist, what exactly needs to be worked on, what the deficits are, what are our goals still. So that's what I do. So my prescription for physical therapy is a little bit more detailed than a primary care physician, but I can't see everybody. There's two of us. There's two physiatrists, here that work, in Buffalo at this unit. There's this few outpatient physiatrists out there that are more involved in spine issues, general joint and musculoskeletal rehabilitation. But in terms of just neuro rehabilitation specialists, there's two of us here. We've been trying to recruit more for years, but once the residency for rehabilitation medicine closed down here about 13, 14 years ago, pool kind of dried up. So that's sort of the challenges.
It might be a little sore subject, but I can tell you, so I recently applied for a major NIH grant for looking at stroke therapies, all stroke therapies. So we currently are part of the consortium, which is, I think, 12 or 13 hospitals run out of Columbia University in New York City. And we, in Buffalo, are personally responsible for 65 to 70% of all clinical trial enrollments for the entire network. And we thought, Amit and I, we did this together, we thought we could stand our own 2 feet and be our own center. Why do we need to be, affiliated with Columbia? We could stand our own feet. But the primary critique that came back, and I got to share that with you, is that we have no presence academic presence in neuro rehab. That was the biggest shortcoming we had for Western New York. And I think that's something that the dean of the School of Medicine should really maybe sort of pay attention to, is that prevented us. And so if we had more of a residency, a rehab residency, a few academicians, there's a lot that is happening, and then maybe they're the ones who would have the inclination to set up support groups and cheerlead them and work with your organization and ours and others to sort of make things a little bit more palatable. So we do have a problem where we have overworked physiatrists. Gates Vascular Institute is the busiest single stroke site in New York State. Number one. I mean, there's no site in New York City that sees more stuff than Amit and his team do here. So, almost 100% of them have rehab needs.
There's so much opportunity for rehabilitation research. I can't go a week without coming up with a new study that should be done that we just can't do, because there is no academic presence. Without having that academic university, without having those resources, you're really limited.
Correct. Sure. Yes.
So I'm Lisa Thorpe. I'm the director of rehab medicine and the ambulatory side of BGMC. And out of respect for the patients in the room, this is disappointing that we can't challenge our community. It's so exciting to hear the treatments on the acute side. I've been in this 30 plus years, and there's nothing really exciting on the therapy. I'm not going to use the word therapy because that's lots of different words. On the rehab side. And how do we challenge this community? We have the people.
I would make one modification. It's not that it doesn't exist. It's that we don't have it, because we don't have local champions who are out there. Like, for example, Rosalind, my junior partner, just flew in from DC, where she was giving talks on some new therapy for aneurysm or some new brain tumor therapy or some stroke device. Amit, we just got introduced to a brand new clot-busting drug that we're going to potentially run a early trial for clot. So everything on the acute side, and then rehab, we have understaffed, overworked, physiatrists who are trying to cover all.
I think the push Like, I feel like we need an NIH grant to run that primary care doc, the whole team together, and then you collect data and you say, well, look at what we did. Look at the outcomes when we put a team of people together to help a person who's had a stroke in the chronic stage, stay healthy, stay not have another stroke, right? That's how you change policy, is when you put that information together.
Yeah.
And so,
Transmagnetic stimulation has been a topic for
20 years?
Yep.
20 years.
Yeah.
It gets sprinkled out there, but we don't jump on it. We don't.
And it's gotten better, by the way. I mean, it's been around for probably first 10, 15 years. We didn't know what we were doing, but now it seems like the data is, I mean, these are devices approved by the FDA because there is clinical data to support them. And there are other technologies too. Huh? Insurance actually pays for a lot of these therapies as well now, because they have, so the FDA and CMS agreed on a pathway. It's called breakthrough designation. So when there's a treatment that's considered breakthrough, it comes with reimbursement. And so it gives the device or drug company a faster path through everything. And there are a few different technologies that are in the breakthrough designation. Well, I think this was fantastic. We all realize what we need. Now we need to figure out how to go about it. But at least the first step is always just getting together and thinking about it. So thank you very much. Thank you. Thank you.
Hello, everybody. Thank you for having me today. I'm the founder of Parkinson's Boxing, and we've developed a novel movement-based program based on skill sets that fit together cognitively through meaningful learning, forcing two or more neural networks to fire in sync. Basically, neuroplasticity with a little twist. We're totally data-driven. We had the largest study given on falls for Parkinson's patients, and we've proven we can reduce falls 87% the first 6 months after implementation. That's been published. Can you take me right to Kathy O'Leary? One more, please. I'm going to let Kathleen tell her story. Okay, she's working with us now.
My name is Kathy O'Leary, and I was totally healthy and fit until October 2019 when I had a devastating stroke at the age of 57 that left me paralyzed fully on my left side, my arm and my leg, and I had no sensation in my arm or leg. As a result, I couldn't walk at all. I had been chief of anesthesia at Roswell Park Cancer Institute right up until that day. I had been there for 25 years. My stroke left me unable to take care of patients and left me absolutely devastated. Eventually, through physical therapy, I was able to learn to walk, and I can now walk with the assist of a brace, sometimes on my leg, and always using my cane. About 3 months ago, I started coming to Parkinson's Boxing after a friend of mine was diagnosed with Parkinson's disease and started coming here. And she told me that she had discussed my situation with Dean and that he had had success with working with stroke survivors in the past and was interested in working with me. So here I am 3 months later. I started coming twice a week, and now I'm up to four days a week. I work every day that I come with a trainer who's with me one-on-one the whole time. They put me on the stationary bike in the beginning, and I couldn't even make one revolution with my left leg isolated alone. And now I can do up to, I don't even know, 50 or 100 revolutions with just the left leg. We're getting to the point where we're not even counting, we're just looking at time that I can stay on the bike. So in addition to gaining strength in my leg with being on the bicycle, Dean and his trainers have been working with me to try to get sensation back. And slowly but surely, I'm starting to get sensation from the top of my skull down to my wrist, and then from my hip down to my toes. And that's huge because I hadn't really had any sensation at all prior to coming here. But every time that I'm here, we work some more on it, and it seems like every day that I'm here, I gain a little bit more sensation.
This program is not just for strokes.
My name is Kathy O'Leary.
It's for anything. We've had tremendous positive results for everything other than late stages ALS. We've had some improvement with late stages ALS, but nothing that was really life improving. I want to show you, I think I'm going to show that video with the lady, please. If I preface it myself, you probably wouldn't believe it. So I'm going to let this kid's mother tell a story, okay, of his journey before he came to us. And he has FND, functional neurological disorder. It's similar to a stroke, other than they lose the signal. There's no signal from the brain to whatever body part is affected. This is his mother, and she's going to tell the story, and then you're going to see the effects.
Hi, my name's Joanne, and I'm here to talk about my son Frankie and to tell you how Parkinson's boxing helped him regain use of his leg. When Frankie was 20 years old, he suddenly lost the use of his leg. He could no longer move his toes, he couldn't lift his foot, he could barely walk. He had to use a cane, and that leg dragged behind him, causing holes in his shoes and sneakers. It all started in February of 2019, about a week after Frankie had fallen and landed on his back. He wasn't really injured, yet he was sore, and he limped around a little bit for about a week. He kept saying he was fine, he was just a little sore, and that's why he was limping. And there was no visible injuries, but he took a pretty good fall on the ice. On February 4th of 2019, his boss called me and said he was very worried. Frankie's dragging his leg. He's very concerned for his welfare. I said, oh yeah, he had fallen. He's been limping around. He said, no, this is different. He's actually dragging his leg. I told his boss, I'll be right there. I picked him up and I took him right to Buffalo General Hospital. I didn't know what was going on. Was he having a stroke? Like, why is his leg dragging? Why can't he move his toes? Why can't he lift his foot? I mean, it was so bizarre, and it was basically like a sudden onset. He went from a limp to not being able to use his leg at all. The doctors admitted him into the hospital, and he was there for 3 full days. They ran all kinds of tests, an MRI and EMG and nerve conduction tests. They did blood work, they did CT scans, they did all these things. And we were discharged with no definitive reason why my son could no longer walk without a cane. We were followed up with a local neurologist who ran all kinds of tests himself, and he was stumped. He did not know why Frankie could no longer use his leg. He referred us to the Cleveland Clinic. We went off to Cleveland Clinic, and it was there that he was diagnosed with something called functional neurological disorder, or FND. FND is a neurological condition in which the brain turns off the signal to whatever body part is affected, whether it's the arms, the legs, the eyes, any body part. In my son's case, it was his right leg. Cleveland Clinic recommended extensive physical therapy to help that signal turn on again. So we went to a local physical therapy center, and 3 to 5 days a week, Frankie was doing extensive traditional physical therapy. After 3 full months, there was 0 change in my son. And I mean, it was very disheartening for Frankie and for us to see not one bit of improvement. 2 years later, Frankie's still walking with a cane. He's now 22 years old, and We still have no idea when and how we're going to get this signal to turn back on. One night I was on the internet and I happened to see an old article about Parkinson's boxing. And the next morning I called Dean. I explained what was going on with Frankie. He said, bring him in. I think I can help him. We were in there the next morning and Dean and his team did an evaluation and got right to work. And Frankie worked hard with Dean and his team, and within 10 weeks, they had my son walking again. Not only just walking, but walking with a normal gait where you can't tell which leg was ever affected by this FND. I highly recommend anybody with any sort of neurological condition or disorder go and see Dean and his team at Parkinson's Boxing. They are doing miraculous work with their clients and giving people their lives back. They gave my son his leg back, and we are forever grateful for their hard work and dedication to their clients, and especially my son. Thank you.
The program we do is not a cookie-cut program, okay? We work off of live points. We work with neuroplasticity. And in this case, it took us about an hour to find out where we were going to start working with this gentleman. And you'll see his leg, he can't hold his leg up, so we had it propped. I was holding it up, looking for a live point. And after 1 hour, the only thing that moved from his hip down on his right side was the knuckle on his big toe moved 1/4 of an inch. And you'll hear me go, okay, that's it, or something like that. I got cut off, but I knew at that point we could help him. I'll start this right now.
Frank came to us 3 months ago. He came here. He was dragging his foot. He was actually walking on his ankle. Right? Yeah.
Push. Can you see it moving?
Yes. We're looking for a live signal.
Are you pulling it or are you pushing it?
I'm pulling it.
Push it.
You do a lot of upper body stuff.
There you go. Push it.
Did you feel it pretty damn
Push it.
Good, yeah.
Get yours?
Guess what?
You done.
Exactly.
Well, I mean, your shoe's coming off. I know it, but my shoes.
This is Frankie walking forward. He's walking on his ankle. The sole of his foot isn't hitting the floor.
I do.
We couldn't duplicate it.
Are you helping him at all, Dean, or
No,
is he?
no.
Okay.
Frank's trying to walk backwards.
One walking backwards.
You can't do backwards? Okay.
And when you're working with neuroplasticity, you have to build a network as close to normal as you can. So you can see his arms and his feet are in sync. His arms are fully extended, full range of motion as his heels hit. His feet are rolling through bottom. He's pushing off the balls of his feet.
Normal, you know.
This is Frankie
Even
10 weeks
with us
later.
with trained eyes, we don't know which. If to look at him, you wouldn't know which leg he was dragging. So he no longer uses a cane. He drives. He got his life back.
Pardon me? 5 minutes. All right, I'm done?
You've got 5 minutes.
5 minutes, okay. Would you send me the next screen, please? This lady has RSD and Parkinson's as well. The reason I'm including all these slides is it pertains to anything neurological, like I said. This is the lady's first day here. We're videoing her. We track everything. Would you start that, please? There's no range of motion in her arms. She can't send the message to her feet.
Right now, I just
Her
want
balance
to
is
see what
totally
you're
impaired.
capable of.
Absolute fall risk. I'm going to cut it off right here because of our time. Would you please go to the next slide? This is within a year. I'm not sure exactly.
All the way down, turn around and come back.
Same place, but less misses, I think is very good.
Beautiful.
All right, we're going to do one more round of that whenever you're ready, and I'm going to get you up any crossovers today. All right, how you feeling, Mike?
Would you go to the next slide, please?
All right.
This gentleman here, our facility wasn't even built yet. We're assessing him here now. You can start it.
David Gurney.
As you can see, his gait is totally impaired. He can't send the signals that turn around here. There's no range of motion at all in his arms. He's stooped. His legs are bent. And he's shuffling, another fall risk, absolutely.
Oh.
David Gurney going
David trying to walk backwards. If you see his feet, his ankles are gonna hit each other. There's no way he's gonna stand without being supported for very long.
Okay, good.
Next slide you'll see.
Crossovers.
Balance is totally impaired. Can you get back to the next slide?
David Gurney.
Right there.
David Gurney going backwards.
You ready? Okay, good.
Crossovers.
David Gurney trying to walk forward.
Need help, Dean?
Next slide you'll see is 6 months later.
September 7th, or I'm sorry, the 8th, 2022. This is Dave Gurney.
He has full range of motion in his hands. He's walking through bottom, obviously. Limited range of motion in his arms, but much improved. Straighter posture. Would you cut over to the next slide, please? I don't have a lot of time. I wanted to show you exactly. Okay, that's Parkinson's. The next slide you'll see is MSA. That's worse than Parkinson's. Makes Parkinson's look like a day at the beach. Multiple system atrophy. He was exposed to Agent Orange in Vietnam. Can you start at the beginning of that, please?
Good.
You can't send the message to his hands. You can see his knees are all scarred. He fell daily. He has no manual dexterity at all. Here we're trying to get him to walk.
Okay, take another, let's put both our feet over here, okay? So take a
The reason
step.
I'm showing you this program
Just normal.
is absolutely
All we're doing is
effective
just moving over to
anything
here.
neurological.
That's it.
Okay, you can send the last one. I think my time's up. This is 4 months later. Walking backwards, sideways, turning around. And this isn't a dopamine issue, this is a brainstem issue. So the music isn't really turning this on. This is. I guess I'm getting hooked. Thank you, everybody.
So speaking of innovations today, we'll talk about some of those that we already mentioned the names of, but innovations that are currently going on and also in the future in the works. And I'm not affiliated with any of this at all. So as you heard from Dr. Siddiqui and Dr. Kandel, innovations have already revolutionized diagnostic and management of acute stroke. And it's a burden that increasingly we're going to see in the medical field. You see that computer algorithms have been developed to detect stroke early so that we know and we can intervene. There's also development of mechanical thrombectomy so we can prevent further strokes from worsening. But for a lot of our patients, that's still not enough, because there still remains a significant number of patients who develop these morbidities, and there's still a high rate of stroke recurring. So stroke rehab needs to be a focus as well for our development and innovations. And it's actually quite a new topic in medicine. Previously, doctors thought that your brain cells are dead, there's no way to recover, but as we just heard, there's actually a chance of recovering. And a lot of this development happened in the last 100 years, where you have all these world wars and polio, where people can then focus energy into how do we then further rehab. A lot of the terms that we're using tonight, physical therapy, occupational therapy, didn't even exist almost 100 years ago. So as we talked about, currently, once a patient had a stroke, and whether they had a mechanical thrombectomy or not, within 48 hours, as long as they're stable from a medical standpoint, we have our rehab team evaluate them. They either progress to long-term facility, rehab hospital, or home with physical therapy, and multiple things. One, to assess the function of our patients and to maximize the individual care for them. And the goal of them is one, physical therapy. Stroke affects movement a lot, so how do we regain that function and improve that? Occupational therapy, a lot of our patients that have speech that's affected, how do we then improve their comprehension and their speech? And also, just as importantly, their cognitive and emotion, how do they then now deal with this new stroke? How does the family then support them? So all of this is so important. And there is a major team of interdisciplinary team who are all involved in this, that each part is important in the full recovery of our stroke patients. Now, as you heard from the panel, we still have a lot of challenges, workforce, limited resources, for our patients, limited resources to get to our available medical staff as well. So the goal of rehab ultimately is, regardless of what method, to maximize the quality of life and independence of our patients for all of these venues. And so some of the ideas of what innovations can do is, one, can we relearn or replace the existing neural circuit for function? Two, can we improve patient accessibility to care, get them to care or get care to them? Can we increase patient engagement, especially our patients with brain injury? How do we engage them more? Can we alleviate our caretakers' burden? And also, can we assist our patient to navigate the health system? There are more than 10, 20 professionals who are all involved in the care. There's so much data to navigate. How do we put all of that together to maximize our stroke therapy? So when you first think of innovations, telestroke, it's actually not a very new concept. Back in the 1990s, once with the development of computers, there's already thoughts on how do we incorporate computers, internet into medical care. And it wasn't really until COVID hit that a lot of this has pushed forward. Especially in the inpatient care, nowadays there's a lot of telestroke that happens, especially in hospitals that are not major centers, that they may not have 24 hours neurologists. Now this is routinely used, where when a patient comes in, you would have this computer with the neurologist, and they would actually see the patient, call the team, and that way, a patient can have access to neurologists everywhere 24/7. And the thought is, can we then extend this to more chronic long-term care? Can we use this telehealth to improve communication and information exchange, bringing rehab ultimately to home? Why? Because one, a lot of our patients may not be able to go to hospitals or rehab, or it might be better to be at the home setting. They might be in remote areas that don't have these available resources that we're fortunate to have here. And again, it might assist caretakers' burden. A lot of our stroke patients with deficit might have very difficult trying to either remember or get to these medical care. So can we alleviate that by bringing rehab to home? And certainly there's been a lot of studies out there to see, is this better or is this comparable to our existing rehab? And this study, at least coming out of UC Irvine, supported that at least it increased rate of participation because of the convenience, and also maybe comparable to in-person. And you also have larger studies that looked at, is this just as good as in-person rehab? And they're saying it's not inferior. Not inferior doesn't necessarily mean it's bad, it just means it's not any better, but maybe it's still good. But since COVID, this is still relatively new. There's still a lot of development into it, so not a lot of data yet, but this is something that's promising. And ultimately, the key to adapting to any new therapy, first of all, it has to work, so efficacy is important. It has to be available to the patient. Ideally, it would be low cost. And ideally also be not invasive, not like a surgery. And speaking of availability, a lot of innovations have been gone into, are there everyday gadgets that we can use for innovations? So you can see, I'm pretty sure everyone in this room today has an iPhone or an Android, right? And 97% now in America has a phone. And 85% of them are iPhones, which is significantly up from even the last 10 years. And so because of this, there's been an explosion of available apps and innovations on the mobile phones. If you just Google apps for stroke recovery, you're going to get hundreds and hundreds of searches, but this is one of my favorite. This is from the NHS from the UK. And what they did was they took patients and also physicians, and they curated a list of the apps that they feel best maximize stroke care therapy. And it ranges all the way from thinking cognition. There are apps that are for movement of fingers. There's apps for vision. There's also apps for mood and healthy living. But this is great because they're convenient, they're low cost, low support, they're trackable. But maybe too many apps, when you have too many things going on, that might be hard to manage. And also, there are some studies, and more studies have looked into this, but there's some concerns of our population of stroke may be a little older. They might not be as fancy with the apps. And also, there's too many going on, they're hard to connect to. And also, a lot of these apps currently do not then go back to the physician or the care team, so there's still this disconnect currently happening right now. So there's more effort into can we then develop apps for platforms for stroke patients specifically. So a couple of apps here that shows maybe they can then develop apps specific for stroke patients, but this is still relatively new. And then another development in innovations is wearable technology. So by definition, wearable technology is any technology that you can wear. It can be jewelry, accessories, medical devices, and clothing. And all of us in the room are also very familiar with what these are, and a lot of commercialized products are now advertising this health part of their product. And a lot of these wearable technologies focus on two major categories. One, quality of life. Can we track stress, sleep, general location of our patients? And then second, also prevention of strokes. Some of these sensors are interesting because, for example, they might be able to track atrial fibrillation, which is a risk factor for stroke. Diabetes is a known risk associated with a stroke recurrence as well. And also other neurologic associations like seizures, fall risk, sleep apnea. And the good thing is these data collected can then also be sent to the medical team. So there's a way to collect the data and store it and ultimately develop an individualized plan. And early studies do suggest that these accelerometers, these wearable technology may improve patients who've developed stroke. So those who didn't have these wearable compared to those suggest that maybe they benefit the stroke rehab recovery. This is actually a grant done by one of my colleagues back at Brigham in Boston, one of our neurologists who just got this NIH major grant. So what they're looking at is a wearable technology. It's essentially a camera, but it senses as our patient goes around and interacts with different people, it senses familiar faces, and then it tracks who these people are, and then it builds this network, ultimately to study the social interaction of our patients, because post-stroke is not just about moving or speaking, but the social interaction, returning to daily function is so important as well, and this is something that they're developing. This is another interesting development going on right now. Won't go into a lot of the science because I don't even understand a lot of the sciences behind it. But basically they're saying, is there a way we can develop a wearable technology that can detect, for example, atherosclerosis, the level of stenosis of your vessels, which is also another risk factor for stroke. So clearly a lot of development into what we can do from a wearable opportunity. So then another common topic is the introduction of virtual reality and augmented reality. So virtual reality and augmented reality are almost always used interchangeably, but they're actually very different. Virtual reality is when you have the headset and you're fully immersed in the environment. You don't even know who's beside you, and you can bump into someone and fall and trip. Augmented reality, on the other hand, is involvement with the environment. So the only way I can explain it is Pokemon Go, right? So you're in the environment, and there's this, in your phone, there's this augmented reality, something on top of it. Integration of the environment. And integration of the environment, augmented reality is now very commonly introduced in, at least in surgical training and surgery. You can see we can use augmented reality where we have a patient there, and you can merge the CT or MRI scan and actually see where tumors are, where aneurysms are. So very exciting in the medical field. And virtual reality is increasingly used in medicine for education in teaching our medical students, teaching our residents. We now a lot of the times have virtual reality simulating different cases for our residents before they actually are in there. And it's even useful for our surgeons as well to look at the anatomy and prepare. And the great thing about this is it's completely safe. It's great for our trainees to develop the understanding of anatomy, understanding of specific procedures before they actually go for real surgery. And virtual reality has also been supported in a lot of different diseases for ameliorating them. For example, chronic pain, depression, dementia, PTSD. So there's a lot of effort also looking into, can we use this new technology and innovations in stroke? And the idea being that a lot of the times with virtual reality, you can practice tasks over and over again. Part of your brain is learning by imitation, so if you have a trainer there, you can stimulate your mirror neurons. And also you have augmented feedback, and you get the individualized care as well. And it's easily accessible. You can also have this at your home. The recent paper published in Stroke does suggest that having virtual reality improves activity of daily living for our stroke patients. This is an example of further innovation. So this is a platform where virtual reality is designed for stroke rehab. So when patients have the goggles on, they're doing everyday tasks almost like they're in the outside environment, practicing how to live a normal life again before they actually go into the real world. The next step then is translating that to augmented reality, and still a lot of active research into that, but not as established as VR. So another idea is, can we use innovations from other types of diseases, other technologies, and translate it to stroke? And some of you have already mentioned that. So deep brain stimulation, very well established for Parkinson's disease. Neurosurgeons implant an electrode directly into an area of the brain. You bring a battery and you stimulate that area for movement. This has been explored in the early 2010s. In animal models, DBS restore movement for these models of stroke, specifically targeting another area of the brain, just like Parkinson's in the cerebellum. The hypothesis is with the stimulation of these, it improves the nerve cell's ability to regrow and increase. And of course, in this model, it works, but does it actually work in patients and in human? So this is a study that's coming out of Cleveland Clinic. They've been leading a lot of this, looking at, this is a phase 1 trial, Eden trial, electrical stimulation of the dentate nucleus, the area, for stroke. First in-human trial for DBS for post-stroke rehab patients, and 9 out of the 12 patients exhibited improvement in motor impairments and overall function. Now, of course, that's only 12 patients, so significant effort is still needed, but this is promising results for neurosurgeons. Vagal nerve stimulation, you guys mentioned it a bit. Vagus nerve is one of our cranial nerves, is the longest nerve that is involved with the autonomic nervous system. And the idea is similar to DBS, where you're stimulating, instead of directly stimulating the brain, you're stimulating the nerve that is then stimulating the brain. So by stimulating this nerve, you are then giving electrical impulses and activating the brain. This is FDA approved for upper limb function for post-stroke. Mayo Clinic is another center that is leading this. And the reason why the argument of VNS over DBS is it's less invasive. DBS involves direct electrode sticking something inside the brain. VNS is a neck surgery where you're putting electrodes around this nerve. So relatively safer, and you're not doing brain surgery. This is a paper that suggests that VNS would be promising for long-term recovery for stroke. So as we mentioned, these both involve surgery. Yes?
I'm aware of a study out of University of Pittsburgh where they implanted something that was like supposedly the size of spaghetti.
Uh-huh.
And it allowed a stroke survivor to gain mobility in their arm. Would that be VNS or DBS?
That would be VNS. So VNS is at the neck. The nerve comes down. So the spaghetti is the actual electrode. So you wrap it around the nerve here, and it stimulates this nerve, and that stimulates the brain. DBS is an electrode that you directly stick inside the brain, and that stimulates the brain. Yeah, of course. But both require surgery. So there is also active research into can we non-invasively stimulate the brain by magnetic transcranial stimulation. Still a lot of data to be studied there. But some promising results, the idea being maybe we can non-invasively stimulate the brain without having to stick something inside the brain or open up the neck for surgery. This is an example of one of these in development where they're using EEG, EMG, and MEG and customizing it to the patient and then stimulating it. So of course, we can't talk about innovations without talking about the brain-machine interface, because we're all thinking Terminator, can we somehow put something in our brain and then we can have a robotic arm or we can move again? So back in the 1990s, 2000, a lot of development into brain-machine interface. Essentially what it means is, can we interpret the signals from the brain? For example, record the signals in the motor cortex where you move, put it into the computer system, do some magic with the computer, and then have the computer interpret it so that it can do that function. So motor is the first one that's been studied, widely studied, and we know it works, where we're interpreting data from the motor cortex. The computer interprets, understands what you're telling them about, and then it actually does that movement. But the newer exciting thing recently in the last couple of months is coming from our colleagues from UCSF. So Dr. Eddie Chang is a neurosurgeon who is piloting this. Is not only can we understand signal in the motor cortex, but now we can understand signal from the speech cortex, and actually by the stroke patient thinking, they can now communicate and have words. The computer is saying out loud words that the patient wasn't able to. But why hasn't it gone popular? Well, multiple things. Variation and consistency is still something to be worked on. This whole computer understanding in a black box is something that we still need to understand. And again, it's invasive, right? Physically implanting this. So for example, this is a grid. This is where the electrodes that's actually placed on the brain. So this would involve craniotomy. You would do an incision. You would take a flap almost as big as the hand, put this on top of the brain, and then close. So it's a relatively big size surgery for this. And that leads to more innovation. So something that we're also part of here at Buffalo, and I'm sure some of you have already heard about Synchron. Instead of actually doing surgery, we're vascular and endovascular experts. Can we put in these sensors inside the vascular system? So instead of doing open surgery, can we insert one of these sensors through an artery, thread it into our vascular system, and detect the signals from there? So the first patient was the first stroke patient was performed in Buffalo here. This is an active, ongoing major trial going on. Essentially, this is like a Bluetooth. You have a stent that's in one of your major vessels. This is our endovascular, so they put the stent through one of your artery in your arm or your leg, thread it up to the vein, you open it. The process takes maybe 1 to 2 hours of surgical time. And then afterwards, when that stent gets incorporated, it starts getting the signals, it starts interpreting the signals, and then some of these patients can we then understand either speech or have it use it like a Bluetooth where they're now able to understand movement in a computer or even movement of robotic arms. So let me play this. Can we play this video?
Here we present the first patient treated in the world with a synchron neuroprosthetic.
Oh, no, you could just play it.
Implant in a stroke patient. Specifically, this is a 44-year-old patient who suffered a pontine stroke from a vertebral dissection in 2009. This left her, unfortunately, with spastic quadriparesis. In order to implant this synchron device, we use neuronavigation prior to the procedure in order to obtain precision accuracy where the device will be deployed in the superior sagittal sinus. Here you can see the wire is being delivered distally into the superior sagittal sinus, over which we deliver the TrackStar system. You can also see that there are 2 needles placed in the scalp to help us obtain precision accuracy for the deployment. This is based on the prior workflow with neuronavigation. Once we are distal in the superior sagittal sinus, we then begin to bring up the device. Once we deliver the synchron device tip to tip with the TrackStar, we begin to then unsheath the device. We can see the array being delivered with precise accuracy in between the 2 needles. Angiography of the venous system confirms excellent delivery, and then we proceed to implant the battery apparatus in a pocket in the chest cavity. The patient was treated successfully and extubated after the procedure. We look forward to assessing her progress as a first stroke patient treated with the synchron technology.
So in conclusion, we went through a lot of different technologies that are active right now, that are in the works in the future, but ultimately we want to return our patients' functions and well-being. And these innovations and technologies are used for engagement, effectiveness, accessibility, individualized care, and a lot of efforts, including Synchron that you just saw, is we're part of UBNS, part of JI, pushing these innovations for post-stroke recovery. So, all right. Any questions? Thank you.
Are there any questions? I know we're past time, it's 6:45.
I just have one
Yes.
question. So how did the patient do?
Yes, so it's a first trial. The patient, they needed to wait a little bit for the stent to be epithelialized. So the stent needs to first get incorporated into the vascular system, and then they need to record the signals. It takes some time for them, a couple months, to record the signals to understand what it means, and then they will start interpreting it. And in their website in Synchron, they haven't done this. This is the first patient, so they still need data. But they've done patients with ALS, with other diseases affecting paralysis. And those patients were able to use their mind, think on a screen, able to type an email. They were able to click different things, like thinking with your mind to do things. And that was very promising for their first few. This patient is still the third, fourth in the whole country, so very, very new technology, but promising in that it's a procedure that's much less invasive, and it's something that can restore our function for our patients. But still a long road for it to eventually become commercialized and everyday use. Yes?
Who's doing vagal nerve stimulation here in this area for stroke survivors?
Good question. I don't know.
No one yet. I saw Jonathan Riley, and he's doing it for other people, but he wasn't doing it for stroke.
Yeah, we'll have to look into that. Yeah, Dr. Riley is certainly, he's doing it for vagal nerve, most likely for epilepsy. Yeah.
Actually, there was someone who was doing it, I think, in Rochester for depression.
Okay.
Yep. So, yes.
Interesting. Yeah, we'll talk to Dr. Siddiqui, but maybe Dr. Riley does it since he already does the vagal nerve for epilepsy. It's the exactly same procedure, but some of the functional analysis might be a little different.
Could you just go back to the NHS?
Yes.
That was very good.
Oh,
Just hold on for a second, because those of us who are here won't have to go that quickly. And we can share this with anybody that comes.
yes.